Hello, my name is Amelia Seasholtz, and I am a first-year osteopathic medical student at the Ohio University Heritage College of Osteopathic Medicine. Today I will be presenting a case of Amyand's hernia, a rare subtype of inguinal hernia where the appendix is contained within the hernia sac. While often requiring surgical intervention, this case highlights a non-operative approach through successful manual reduction. This demonstrates how early recognition can help reduce morbidity and allow for elective surgery rather than emergency surgery. Amyand's hernia occurs when the vermiform appendix becomes entrapped within the inguinal hernia sac. As you can see in this artistic depiction, the appendix herniates with the small intestine through the inguinal canal. The statistics show that this occurs in as low as 0.19% of all inguinal hernia cases, with 91% of cases being male. It is also 3 times more common in children. Management strategies depend on the presence of inflammation or obstruction. If the appendix is inflamed, incarcerated, or perforated, an appendectomy with hernia repair is required. If the appendix lacks these characteristics, manual reduction can be attempted first to avoid unnecessary surgery. Now let's take a look at the clinical presentation of this case. A 57-year-old male with a history of sigmoid diverticulosis presented to the emergency department with a 2-day history of severe bilateral lower abdominal pain. Physical exam showed he was afebrile but tachycardic. Abdominal exam showed diffuse pain with guarding, no rebound tenderness, and normal bowel sounds. The groin exam showed a 2-centimeter painful lump in the right groin, consistent with an inguinal hernia but without overlying erythema. To confirm the diagnosis, an abdominal CT was performed, which revealed the following: acute sigmoid diverticulitis with bowel wall thickening, multiple diverticula with fat stranding, bilateral inguinal hernias, and Amyand's hernia with the appendix herniated into the right inguinal canal. If you compare the left and right side, you can see the appendix and part of the intestine filling the inguinal hernia on the right side, indicating an Amyand's hernia. The appendix appeared normal, without inflammation, obstruction, or perforation, suggesting that manual reduction could be attempted first instead of immediate surgery. Given that the patient had no signs of appendicitis or strangulation, the decision was made to attempt manual reduction first rather than proceeding with immediate surgery. This approach was particularly important because his acute diverticulitis placed him at higher risk for post-op infection if surgery is performed at this time. In this case, the patient was first placed on IV antibiotics to manage his acute diverticulitis. A surgical consult was obtained, and manual reduction of the Amyand's hernia was successfully performed. Following reduction, the patient's abdominal pain and leukocytosis resolved. He completed a 2-week course of antibiotics for his diverticulitis, and he later underwent an elective bilateral hernia repair without appendectomy. Successful reduction was confirmed by the resolution of pain, no persistent lump on examination, and no signs of bowel obstruction, specifically no nausea or vomiting. In summary, this case demonstrates that in non-incarcerated, non-inflamed cases, manual reduction can be a safe and effective alternative to immediate surgery, reducing morbidity and unnecessary appendectomies. By applying these principles, clinicians can recognize Amyand's hernia early and determine when surgery is necessary. They can use manual reduction techniques to manage select cases non-operatively and improve patient outcomes by preventing emergency surgery when possible. I hope this case presentation provides you with a framework for managing patients with Amyand's hernia. Here are the references. Thank you for listening.